Okay.
Hi, my name is Jerry Hesch. I'm a physical therapist and developer of the Hesch method of treating the SI joint, etc. I have two websites, www.heschmanualtherapy.com and www.heschmethod.com. I have a very interesting client that I wanted to capture on film, and she's been very kind in allowing me to do so. And I want to just talk about my findings here. And so hopefully I can talk in less than 10 minutes. We can post these on YouTube, and then I can post the evaluation, and then I will post the post-treatment effects. The treatment takes a fair amount of time and multiple positionings and such, and it's not appropriate to show treatment on the website. So we won't show the treatment, but we will show the after effect. And those who study with me can learn how to do the treatment. Okay. This client has had a neuropathic itch for a very long time that has not been adequately treated with multiple consults with allergy and dermatology and such. And she does correlate it with some mechanical dysfunction in the pelvis/SI sacroiliac joint. Now, she did start out with some itching in the digits and then in the toes, but the severe itching that she can partially control when she self-treats the pelvis and uses an SI support is in the pubic area, in the pudendal area, and the anal area as well. Okay, so her findings, she also reports to have multiple trigger points throughout her body. And I've noted, as has another therapist, that she has kind of a mixed presentation in terms of some joint hypermobility, such as in the 5th MP. I can bend that finger 90 degrees and even further. But when I test the elbow, there is no gunstock deformity. When I try to hyperextend it, it's nice and solid. So she has that mixed kind of thing of where one joint is hypermobile, one is not. Okay, other findings are she also reports to have a mild mitral valve regurgitation, which hints at a connective tissue disorder, and she also has interstitial cystitis, which she's had for quite some time, a history of migraines that are controlled with medication. Okay, in terms of the lower extremities, her left lower extremity appears to be about 9 millimeters shorter. When she puts a 9 millimeter lift, her pelvises do achieve symmetry in standing. The right fibula is stuck inferiorly and anteriorly, so that may feed into that. She also has significant, surprising amount of laxity in the left subtalar joint and the left ankle. She does get episodic vertigo. The right femur is stuck in what I describe as posterior glide, and you may also call it stuck in flexion. She lacks extension in that femur. She cannot get past 0 degrees, whereas she has 15 degrees of extension in the left femur. Now, because the femur is a bowed structure, when the femoral head is stuck posterior or in glide or else stuck in flexion, the whole thigh will look forward, as will the lower leg. The tibia will appear forward. Now, when the hip is flexed, even if slightly, okay, sometimes you'll glance at it, it doesn't appear to be in flexion, but it is. What happens is because it is flexed in the hip, the knee is also flexed. So when you come and clasp the patella and try to do an anterior lift, you cannot. And when you try and spring the femur posteriorly, it's stuck, whereas you go to the other side, which is normal, you can spring that structure along its entire length. Now again, it appears to be anterior except when you come up in the region of the neck of the femur, then that portion appears to be more posterior in comparison to the left side. Okay, moving beyond that, now to a theory is that when she walks, after a heel strike on, can you capture me, can you follow me? After you hit the heel here, at this point when your foot is flat, this hip needs to extend like this in order that you can move your body forward. Well, she doesn't have this ability. So what we believe that she does is that she twists to the right. And the reason we speculate that is because in standing, the pelvis looks like it's twisted to the right, but as soon as you lay her on her stomach, that goes away. Okay? I did not do an extensive gait evaluation. Unfortunately, I didn't. We will do one later after the fact, but in the interest of time, I'm going to keep speaking. Okay. When I palpated the pubic structure, the pubic bones and the fibrocartilage, I was just fascinated with what I found. And what I found is that I found symmetry of the pubic bones along the entire length. Some philosophies don't palpate the bottom portion of it, the bottom half, and I think you need to. But when I come across, and the heights are equal, and in terms of anterior-posterior relationship, those are symmetrical. But when I palpate the fibrocartilage in the middle, it's wide, okay? I'd like to look at an x-ray and measure it there as well. But what's fascinating is when I come off each pubic bone, I fall into the fibrocartilage deeper than I have ever seen in another client. So the fibrocartilage has slipped posteriorly in her body, okay? And that certainly is going to create a wedge, you know, because a wedge, it's going to alter the mechanics in the pubic joint, and it correlates beautifully with what we find in the sacrum. What we find in the sacrum is that her sacrum is stuck in posterior glide. It's prominent in relationship to the ilia, and nowhere, no quadrant, midline, right side, left side, top, bottom, can I create any spring mobility. Now if I go to L5, I can take up the slack, stay there, induce 15 pounds of force, and L5 will move and recoil like a normal structure. But once I get on that sacrum, it is absolutely stuck. And I think that really is driving the system. It continues to get interesting. On the left side of her body, she does present with a left upslip. The ilium is stuck. I cannot spring it inferiorly in the front. I cannot spring it inferiorly on the posterior iliac shelf. When I come underneath the ischial tuberosity, I cannot spring it superiorly. Okay? When I palpate the sacrotuberous ligament, it actually feels like a ligament, but I'm sure it's a little bit softer than normal because it would be shortened in an upslip position. On the right side, the sacrotuberous ligament feels like a rock because the right is stuck in downslip, okay? And I can't spring that one either in those directions. So palpating that ligament is very, very important when you want to distinguish between an upslip and a downslip. Okay. What I find in response to that, the compensation is that the mid-body of her sternum is stuck. I can spring, you find the xiphoid, never spring the xiphoid, come above there to the lower sternum. I can take up the slack, I can spring it, it moves and it recoils, and I come to the mid-body and it's absolutely stuck. She feels the same thing. Now that correlates exactly to the sacrum. When we restore mobility in the sacrum, I fully predict the mobility in the sternum will be released. And that's behind one of the major curves. That's behind the normative kyphotic curve in the thoracic spine. And then you have another curve, you know, at the CT junction, and then another curve in your neck, and at the top the mechanics change as well. She is stuck at the occipito-atlantal joint. When I, you know, try and shear her occiput posteriorly on a stable upper cervical spine, it's absolutely stuck. When I try and glide the occiput anteriorly or posteriorly and do the same thing at C1, no movement whatsoever. I can come, and same thing with side glide on the transverse processes of C1, absolutely no mobility. When I come to C2, there's definite normative mobility, which is probably a little bit hypermobile, but per my, you know, limited skills, I cannot make that kind of a distinction. Perhaps some people could, or maybe in a research lab we could, but for our purposes, C1 is stuck, occiput is stuck, and I believe that that too is related to the sacrum, and I believe that'll be much easier to treat once we make the correction of the sacrum, you know, and everything proximal, especially the symphysis pubis as well, because that works with the sacrum. We're approaching 10 minutes here in this dialogue, and so I'll stop talking shortly, but not quite yet. We could spend a lot of time screening her strength, and I know that she's been working hard on stabilization exercises. She's been working hard on getting trigger point massage throughout, and seeing a pelvic floor therapist as well. Hopefully we can make a big input into this problem and reduce over time the need for that care, and enhance her ability to tolerate, you know, full body strengthening and make some real strength gains. When you have a mechanical dysfunction, you have inhibition of certain muscles, and you're fighting reflexes and you're fighting Mother Nature. When you reduce the mechanical dysfunction, the rest gets better, and I've got to stop here. Thank you.